Welcome, colleagues. It is a privilege to be with you today as you embark on what I consider to be one of the most rewarding transitions in modern medicine. I am Dr. Daniel Bates's AI avatar. I'm your expert medical educator and executive coach. And today, we are diving deep into the foundational lecture of your onboarding titled PACE Architecture and the Executive Medical Director. For many of you, the last decade or more has been defined by the relentless pace of the fee-for-service treadmill. You have operated in a fragmented system where your clinical brilliance was often stymied by the silo effect, where the cardiologist doesn't talk to the social worker and the hospitalist has no idea what happens in the patient's living room. Today, that changes. By stepping into the role of a medical director for a program of all-inclusive care for the elderly, or PACE, you are moving from a world of transactional care to a world of transformational leadership. Our core learning objectives for this session are twofold. First, we will delineate your leadership role not just within your local organization, but within the broader framework of the National PACE Association, or NPA. Second, we will distinguish the vital difference between providing direct patient care and exercising executive clinical oversight. Before we begin, please have the two handouts provided for this session nearby: the organizational chart templates and the NPA Medical Director role description. We will be referencing these throughout our discussion. Why is this high stakes? Because in PACE, you are the clinical conscience of the organization. You are no longer just a doctor, you are a healthcare executive who owns the full financial and clinical risk for a population of the most complex, frailest seniors in our nation. If a participant falls, it is not just a clinical event, it is a failure of the system you oversee. If the budget collapses due to unmanaged hospitalizations, it is your strategic leadership that must find the path forward. Let us begin our first module. To lead in PACE, you must first understand the architecture of the house you are living in. PACE is not just a program, it is a fully integrated, provider-led, capitated health plan and healthcare delivery system. It is the only model in the United States that assumes full financial risk for both Medicare and Medicaid services, integrating them into a single pool of funds. Think about the traditional Medicare system for a moment. It is designed to pay for sickness. In contrast, PACE is designed to pay for health, autonomy, and community preservation. The PACE program rests on 5 non-waivable principles: a focus on the frail elderly meeting nursing facility level of care, comprehensive and integrated services, an interdisciplinary team approach, community-based service delivery, and full capitated risk. What does full capitated risk actually mean for you as a medical director? It means that your organization receives a fixed monthly payment from Medicare and Medicaid. This payment is all-inclusive. Whether a participant needs a $10,000 a month medication or a $50 ramp for their front porch, the money comes from the same pool. This creates a powerful incentive to innovate. In traditional fee-for-service, you cannot get paid to visit a participant's home to check their rug for trip hazards. In PACE, if that $50 rug check prevents a $50,000 hip fracture, you have achieved the ultimate goal of value-based care. When we compare these models, the differences are stark. In the traditional world, volume is the primary revenue driver. In PACE, it is the risk-adjusted monthly payment. Traditional care is fragmented and clinic-based. PACE is fully integrated and exists wherever the participant is, at the center, at home, or in the community. Now let's talk about your dual identity. You are a clinician executive. While you may manage a small panel of patients to maintain your clinical skills, your primary responsibility is the entire medical service team. You are the one who develops the clinical policies. You are the one who ensures that care is culturally sensitive. You are the one responsible for the clinical outcomes of every single participant, whether they are in the PACE Center, an acute hospital, or a skilled nursing facility. This transition requires a psychological shift. In fee-for-service, your success was measured by how many patients you saw in a day. In PACE, your success is measured by how many hospital days you avoided for your entire population. You are moving from a me mindset to a we mindset and eventually to an enterprise-wide mindset. We cannot talk about leadership without talking about the law. Your role is defined by federal regulations under 42 CFR Part 460. If you look at your handout on organizational charts, you will see where the medical director sits. You are not just a lead physician. By law, the PACE organization must employ or contract with a medical director who is responsible for the delivery of participant care, clinical outcomes, and the implementation of the quality improvement program. This is a heavy mantle. It means you are legally accountable for the Quality Assessment and Performance Improvement Program, or QAPI. You must ensure that the organization's data is used to demonstrate internal improvements in outcomes over time. You are the one who ensures that medical staff, including contracted specialists, meet the same high standards as your internal team. Let's look at a realistic scenario. Suppose your PACE center is undergoing a CMS audit. The auditors will not just look at your charts, they will look at your meeting minutes. They want to see that the medical director is actively chairing the quality committee. They want to see that when the data showed a spike in falls, you didn't just shrug, you led a root cause analysis, you revised the physical therapy protocols, and you evaluated the competency of the home care aides. Regulatory compliance in PACE is a clinical safety net. For example, regulations mandate that medications must be dispensed no later than 24 hours after a provider orders them. Why? Because for a frail 80-year-old with heart failure, a delay in starting a diuretic is the difference between staying at home and an emergency room visit for pulmonary edema. As medical director, you own that 24-hour system. Take a moment to look at your handout on the NPA Medical Director role description. You will see that your duties extend to reviewing credentials and delineating privileges. This isn't just paperwork. In a traditional clinic, you might not care how the local podiatrist documents. In PACE, you must care, because their documentation impacts your risk-adjusted revenue and the participants' safety. Moving into our third module, let's discuss leading the interdisciplinary team, or IDT. If PACE were an orchestra, the IDT would be the musicians and you would be the conductor. But here's the catch. In this orchestra, the driver and the nurse have an equal say in the performance. The IDT is the core clinical decision-making body of PACE. It is comprised of 11 required members, ranging from the primary care provider and registered nurse to the driver and the personal care attendant. Your leadership within the IDT is perhaps your most nuanced challenge. You are a member of the team, but you are also the one who must ensure that the team's decisions are medically sound and consistent with the participants' goals of care. A common pitfall for new medical directors is attempting to over-doctor the IDT. Remember, these professionals, the social workers, the therapists, the dietitians, are experts in their fields. Your role is to provide the clinical framework that allows them to succeed through respectful collaboration. Let's talk about conflict. Conflict in an IDT is not a sign of failure. It is a sign of a healthy environment. However, poorly managed conflict can lead to fragmented care and staff burnout. Imagine a scenario where the social worker believes a participant is no longer safe at home, but the physical therapist argues that with better equipment, they can stay. In a traditional model, the doctor might just sign an order. In PACE, you must facilitate a consensus. You must ask the hard questions. What are the medical risks? What are the psychosocial risks? How does this align with the Participant Bill of Rights? A key tool for your leadership is the PACE Graded Assertiveness Model. I want you to teach this to your teams. It allows any staff member to safely challenge a leader. It starts with a probe. Doctor, I noticed the patient seemed more confused this morning. Are we sure this is the right dose? If that doesn't work, it moves to an alert. I'm concerned this dose might be causing delirium. Then a challenge. I think we need to hold this dose. And finally, an emergency. Stop. He is about to fall. We must act now. When you create an environment where the driver feels safe, raising a concern, and you listen, you have achieved true PACE leadership. Now let's get into the business of being a medical director. You are now a steward of a multi-million-dollar budget. In a fee-for-service world, you never had to care about the medical loss ratio. In PACE, you do. The PACE organization receives fixed monthly payments, which must cover everything from aspirin to open heart surgery. This is why your role in utilization management is so critical. This is the process of ensuring that medical services are necessary, performed in the right setting, and are of high quality. It is not about denying care. It is about right-sizing care. The National PACE Association provides benchmarking tools like the Rebrick score. As a medical director, you use these scores to see where your money is going. Are your specialist costs 20% higher than the national average? If so, why? You must be able to read an income statement and translate those numbers into clinical action. Perhaps the most important administrative task you will oversee is hierarchical condition category, or HCC coding. Because PACE is risk adjusted, the amount of money you receive for a participant is tied directly to how sick they are on paper. If heart failure isn't documented and coded correctly every year, the organization loses the funding necessary to care for that participant. We are currently transitioning to a new risk adjustment model called V28. This is a major executive challenge. This model removes some conditions that were previously risk adjustable and changes the weights of others. If your providers don't adjust their documentation, your organization could see a significant drop in revenue. As the medical director, you must be the educator for your team, ensuring that every encounter accurately captures the patient's acuity. You might be asking how to find time for all this while still seeing patients. The answer is that you don't do it alone. You work with a quality manager, a finance director, and a clinic manager. But you are the one who provides the clinical rationale for the data. You are the one who explains to the team why a new high-cost medication is actually a strategic investment that will prevent hospitalizations. In the traditional world, once a patient leaves your office, they are essentially gone until the next appointment. In PACE, there is no gone. You are responsible for the participant 24 hours a day, 365 days a year. The PACE Center is your hub. It is a facility that includes primary care, restorative therapies, socialization, and dining. As medical director, you must ensure the clinic operates efficiently, perhaps by incorporating telehealth or creating virtual clinic blocks for participants who are too frail to travel. We must also master transitions of care. The most dangerous time for a PACE participant is the 48 hours following a hospital discharge. This is often described as a hazardous journey. Studies show that poor communication between hospital and primary care providers results in high readmission rates. As an executive leader, you must build a bridging system. This includes hospital in-reach, where a team member visits the hospital before discharge, medication reconciliation performed within 24 hours, and an immediate home visit to assess for hazards. You are overseeing a closed-loop system that spans the entire community. As we move toward the conclusion of this lecture, let's discuss your role as a strategic thinker within the larger PACE movement. You are joining a community of nearly 200 organizations serving almost 90,000 participants. The National PACE Association is your primary advocate. I strongly encourage you to attend the NPA conferences and the Medical Director Essentials course. These aren't just for learning, they are for benchmarking your leadership. One of the key initiatives you will lead is PACE 2.0. The goal is to scale our impact, perhaps serving younger adults with disabilities or individuals with end-stage renal disease. You must make the case for growth. This is where you move from clinical supervision to enterprise-wide strategic planning. Finally, let's address the most profound part of your leadership, end-of-life care. Approximately 95% of PACE participants live in the community, yet they are all nursing home eligible. Many have dementia. You must lead the interdisciplinary team in having what matters most conversations. You are the one who helps the team transition from aggressive cure to aggressive comfort. You ensure that a participant can die with dignity in their own bed, surrounded by the team they trust. This is the ultimate expression of the PACE mission. We have covered a vast landscape today, from capitated financing to the dynamics of the interdisciplinary team. Your transition into this role is a paradigm shift. You are no longer defined by your autonomy as an individual physician. You are now defined by your ability to empower a team and sustain a system. Before we conclude, I want you to commit to 3 immediate action items. First, map your governance. Take your organizational chart handout and fill it in with the names of your local team. Schedule introductory meetings with your quality manager and finance director this week to talk about systems, not just patients. Second, audit one hazardous journey. Identify a participant who was recently discharged from the hospital and follow the paper trail. When was medication reconciliation done? Did the team meet before or after the discharge? Use this to identify where your system needs refinement. Third, review your NPA role description handout. Highlight the areas where you feel least comfortable, whether it is reading income statements or overseeing coding. These are your professional development goals for the next quarter. You have chosen a path that requires the best of your clinical mind and the best of your executive heart. Welcome to the world of PACE leadership. I look forward to our next session, where we will dive into the specifics of quality improvement and data management. Until then, lead well.